virtual event. I'm going to pass to Teresa Sundin, who is my colleague, and she will give us the tech run-through before we get started. Take it away, Teresa.
Hello, everyone. Welcome. I, for the majority of this wonderful meeting, will be muted and video off, but wanted to show my face, say thank you, everyone, for joining. I know that this is our second KCRC Presents virtual meeting. We're so glad to have you back for those who were at the first one. We are using the Zoom platform, as you all know, so thank you to everyone who has muted themselves already. If you'd like to have your video on to see, the virtual faces, please feel free. We are recording this so that we can share it with you afterwards in case you miss a small nugget of wisdom that is shared later in the meeting. We will send it out to you post-meeting. And if folks have questions in the chat, please feel free to put them in there. I will be the Washington Recovery Alliance. You can chat me privately. You can ask your questions, help tech troubleshooting. Everything goes in there. But welcome, everyone. Thanks.
Thank you, Teresa. And now it's my great pleasure to introduce David Coffey, a board member of the King County Recovery Coalition and our parent organization, the Washington Recovery Alliance, as well as the executive director of the Recovery Cafe downtown. David is our moderator today, and he will be introducing our guest speaker. Thank you, David.
Thanks, Heather. And I'm really, really excited to introduce you to Tom in one moment. I did want to say that David Dickinson was going to join us and had a family medical emergency. And so he sends his hellos to everyone. Most of us in the WRA community know him. He's been a fabulous supporter of the work of the Washington Recovery Alliance. Many of you probably already know Tom from Anonymous People. I had the great honor of hearing Tom speak at an ARCO presentation, and he was talking about a Surgeon General report that his team led while he was the Chief of Staff of SAMHSA about the efficacy of recovery support services. And it was just amazing. It was one of those things where I was like, I wish the whole world could be here in this room right now listening to this. And for several years, I tried to get Tom out to Seattle to get in front of several funders, and at the end of the day was not able to get the funders to come to the table. But what Tom has to share, I think, is so important for everyone to understand. And I'm really excited for him to join us on the call today. So Tom has a much, much longer bio, but I think I'm just going to take the ball and pass it right over to Tom to tell us more about this report. And thank you again, Tom, for joining us.
David, thanks so much for inviting me to join you. This is both of our dreams come true to finally be able to chat about this report in Washington State, and we had to have a international pandemic to make it possible. That's probably not funny, but the COVID-19 pandemic has enabled us all, while it's been very, very challenging for all of us and for our country and for our entire world. It's given us an opportunity to be places and do things virtually that we never imagined people would want to do in this format. So this is great. And I want to thank Teresa and Heather as well for having me here today, and for everybody from the King County Recovery Coalition. I love, Heather, your purple background. You'll see in a minute, purple, everybody knows, is a color very closely associated with recovery. And when we were talking about what color the Surgeon General's report would be, we made it purple as a result. So it's great to see such wonderful work being done throughout Washington State. I got to come to Seattle and witness the work that was happening at Recovery Cafe and met David and his team. And I'm so impressed. I mean, it's exactly the kinds of things that we want to be happening in our country. Those are the kinds of things that help people find and sustain their recovery for the long term. And those are the kinds of things that the report looks at. And so it's exciting for me to be able to be with you all again. I consider you guys to be leaders in the field. And while I've been able to do this work for a long, long time now, I really am energized by people like David and the founders of Recovery Cafe and the work of coalitions like the King County Recovery Coalition or the Washington State Recovery Community Organization. It's that kind of work, really the grassroots work of our movement that really helps move the ball forward and helps us be able to all not just enjoy our own recovery, but help others find and sustain recovery as well. So for me, as a person in long-term recovery myself, which means I haven't used alcohol or drugs since May 15th, 2003, that's what makes this really exciting and special to me. And I had some amazing opportunities in that, in the last 17 years in recovery. So for those of you who know my story, you know I'm a former state senator. I served 8 years in the Rhode Island State Senate. I went through my own battle with addiction, got into recovery in 2003, and then really got involved in recovery advocacy. I got to work for a recovery, I got to be on the board of a recovery community organization in my home state, and I got to work for Faces and Voices of Recovery nationally. And then I went back to the state Senate where I once served and became chief of staff to the Senate president there. And the reason I'm telling you that, not just to share biography with you, but to say I really understood in that process, those first 5 years in recovery, how important it was that we show up at public policy tables. Like that, sometimes I was at a public policy table because of my position as chief of staff to the Senate president, and I was the only person there in the room. You know, you guys, I think, have probably had the same experience where you look behind you, hoping the troops will be there to support you, and sometimes there's very few of us. And so, in order to build this movement, we've really tried to place people within government positions, people in recovery who have lived experience, who know know what the journey is all about. And as a result of that, we've been able to accomplish great things like this report that I'm going to share with you today. When I had I went back to work for the Senate president, as I mentioned, when I was there for 6 legislative sessions. And in that 6th legislative session, somebody reached out to me from the White House and said they had a political appointment that was coming vacant at SAMHSA, and they were looking for somebody to fill it. And did I know anybody for that position? And I recommended a few people for it. And then they called me back and they said, hey, thanks for recommending these people for this position, but we were disappointed you didn't recommend yourself. Like, where was your resume? Why didn't you put your name forward? And I said, oh no, I'm too busy. You know, I've got this great job working for the Senate president, and I've committed to her to stay in this position for a while. And they said, yeah, but you know, this stuff takes a long time. Just throw your resume in with the mix and go through the process. And I did. And 9 months later, I was at SAMHSA as the senior advisor to the administrator there. And one of the first things that happened when I walked into her office was she said to me, one of the projects I've always dreamed about doing in the 6 years I've been here is a Surgeon General's report. And I haven't been able to get it done. And would you take on that task? Would you help me make sure that this gets over the finish line in this administration? Now, I had heard about Surgeon General's reports. I knew, but I thought they were all about smoking. I had never really heard about a Surgeon General's report that hadn't had something to do with smoking. Quite frankly, because there were 50 Surgeon General's reports on smoking. I didn't realize there were Surgeon General's reports about other health conditions. And there had not been one on the #1 public health issue of our time, addiction. And that was sad, but it was also an opportunity to get one done in the previous administration. So with that, I'm excited to be able to tell you, and you guys know this because it's been out for 4 or 5 years now, but in 2016, we launched the Surgeon General's report on alcohol, drugs, and health. It was 2 years in the making. We had a very fast timeline for this report. And what Surgeon General's reports is they're a review of the current science. So you very rarely break new ground with a Surgeon General's report, but what you do is you take all the available science, the best science available, you bring it into one document, and you're able to basically show what the evidence is for treatment and for recovery of certain medical conditions, of health conditions. And you can also focus on the disparities in health. You can focus on public policies that need to change. You can provide evidence to get things done that you wouldn't be able to get done otherwise. And while it may sound like like very wonky, a Surgeon General's report, it's actually the tool that advocates can use to raise the profile of an issue and to show that there's great science behind the issues that we're all talking about. Like, we're not making this stuff up. We're not making this stuff up that people have a disease and that they need treatment and they need recovery supports that follow that treatment in order to find and sustain recovery for the long term. This is something that's been studied. This is something that there's evidence behind, and this is something that we need to do more of. So on November 17th in 2016, the first Surgeon General's report on alcohol, drugs, and health was born at a summit in Los Angeles, California, where it was released by Surgeon General Vivek Murthy. And it finally put addiction aside of other public health issues like smoking and cancer and HIV/AIDS and bone density and all sorts of other public health issues that have existed for all too long. And I have a PowerPoint presentation because what would a good government presentation be without a PowerPoint? And I'm going to share it with you just to kind of walk through a little bit about what happened with the report and what it's about and how we arrived at the conclusions we arrived at. So let me go here and start this slideshow. 1 second. Play slideshow. You guys see that okay? Hopefully, perfect. I accidentally hit the share screen again, and now I can't get this off the screen. So give me 1 second. I'll try to do that. There it goes. So the rationale for the report. You guys can see rationale for report on your screen, right? You're seeing the same slide I'm seeing? Great. So this is not going to be any new information for all of you. The U.S. has a serious substance misuse problem. Substance misuse of alcohol and other drugs is in a manner, situation, amount, or frequency that has caused harm to the user or those around them. One other thing I have to do here, give me 1 second. I cannot see my, it has shut my thing off here, so I can't see my clicker. So I can't get around. I'm sorry. The problem is I can't see the slide because the pictures are over the slide. So I don't know if anybody can help me with this. Let me see if oh, here we go. I got it. Now I got it. You guys can still see everything, I assume? David, you can still see everything. Perfect. Great. So start the sharing of this again. Right. So getting back to the rationale for the report, drug and alcohol problems and disorders are major public health challenges that affect millions of Americans, and it places an enormous burden on society. At the time of this report, and still today, we're facing an unprecedented opioid overdose epidemic. There was a question about whether or not we should just do the report about opioids, but since there had never been one about addiction in general, we decided no, that the addiction report needed to come first and that we could follow it up with additional reports later, just like they did with tobacco and smoking. And that's exactly what's happened. There's since been an opioid report. Due to the magnitude of the problem, most Americans know somebody with a substance use disorder, and many know someone who have lost or narrowly lost a family member or a friend to addiction. And our healthcare system has clearly neglected to give the same level of attention to substance use disorders as it has to other health conditions that affect similar numbers of people. Now, in Surgeon General's reports, they use scientific standards to develop the report. And what you're looking for basically when you need scientific standards is you have to prove that something's either has well-supported science, supported science, or promising science. And so as I go through the different chapters, I'll tell you kind of where we landed on each one of those. In cases in which the evidence was based on the findings of neurobiological research, the CDC standards were adapted. And according to the CDC, you're allowed to use these 3 categories of science for the report. And that was important for us because we knew that there's still so much that we don't know about these diseases. They have not been studied with the rigor that other diseases have been studied. And the gold standard of science are randomized controlled trials. And we don't have RCTs in many parts of the addiction continuum. The report's divided into sections, and the first section of the report is an introduction and an overview of the report. Just describes the extent of the substance use problem in the United States and describes the purpose, focus, and format of the report, as well as identifies key terms, concepts, and perspectives. One of the things we wanted to do was, and the Surgeon General really gave this directive to us, is he wanted the report to be readable. He wanted any American family who was struggling with addiction to be able to pick up the report and to look through the report and be able to read it. And so we made sure that we wrote the report in a little different way. It wasn't written for scientists. It was written for everyone. And so we took great pains at using language that was understandable by a majority of the population, and also took the time to identify key terms, concepts, and perspectives. The basic 5 chapters of the report are neurobiology of addiction, prevention, treatment, recovery support, and health systems. Those are the main 5 chapters. And I'm just going to give you I'm going to spend most of my time on the recovery chapter, but just to give you a little bit of information about what's in the other chapters. On the neurobiology chapter, we wanted people to know that addiction is a chronic brain disease. And oftentimes you hear that you have a chronic brain disease and you're like, oh my God, I have a chronic brain disease, I'm going to die. And it's different with addiction, right? This chronic brain disease has the potential for long-term recovery, and we wanted people to know that. So we made sure that that chapter was written with that in mind. It describes the 3 main circuits in the brain involved in addiction and how substance use can hijack the normal function of the circuits. And we wanted people to understand that the transformation in the brain is critical to understanding why addiction is a health condition, not a moral failing or a character flaw. In the prevention chapter, we're really focused on programs and policies on preventing substance misuse, including universal prevention that target the whole community, as well as programs that are tailored to high-risk populations. This chapter also describes population evidence-based policies that are effective at reducing underage drinking, drinking and driving, the spread of infectious disease, and other consequences of alcohol and drug misuse. This is a great chapter because it really looks at 60 evidence-based programs that have proven to not only reduce substance misuse, but also to save money. And I think when David was talking about getting in front of some funders, that was one of the points we were going to make to them, that not only does this stuff make sense to do, not only do you save lives, but you save lots of money. The cost of untreated addiction, this report pegs it at $442 billion annually. And we know it's much higher than that because this report used numbers that were from a 2010 scientific study. The next chapter in the report is treatment. It's called Early Intervention, Treatment, and Management of Substance Use Disorders. Describes the scientifically proven clinical activities that are used to identify people who have a substance use disorder and engage them in treatment. And it also describes the range of medications and behavioral treatments that can help people successfully address their substance use disorder. So we know that people go to treatment and they have really great experiences with treatment. Oftentimes, this is the only disease where somebody who has it and is being treated for it, when that treatment stops and the person has a reoccurrence of symptoms, we blame the person, we blame the individual. We say treatment didn't work. No, treatment worked just fine. When the person was in treatment, they were doing well. When the treatment stopped is when they had a problem. And so what this chapter aims to do is really help wrap that up with a bow and help people understand why treatment has to be at longer durations, and it has to be tailored for individuals' needs. Now, the three chapters that I just covered, neurobiology, prevention, and treatment, all have well-supported evidence. Some of the stuff in the chapters has supported evidence, and so these are the three most rigorously evidence-supported chapters of the report from a scientific perspective. But we had two other chapters we wanted to include in the report, and one was recovery support, and I'm going to cover that last. The other is healthcare systems and substance use disorder. We really wanted to have a chapter in the report that explained why integrating general healthcare and substance use services can result in better outcomes, and describe policies and activities that were underway to achieve that goal. Also, legislation that requires health plans to offer substance use disorder services equitably. We know it as parity. How parity laws that were on the books could be effective if they were enforced. And we wanted to make sure that people knew that innovative delivery system reforms and models of care coordination are available to us, and that there's different financing systems that cover substance use disorders, and that sometimes silos substance use disorders out of the regular healthcare system, and it affects people's outcomes. Now, we don't have, like I said, we have promising evidence, and we have some supported evidence in this chapter, but we knew it was important to include this because if we really want to make a change, systemic change about the way these disorders are treated and the way people recover from them, we need to address the divide between what healthcare systems are able to deliver to people and what the specialty care system is able to deliver. And then the final chapter in the report that I'm going to talk about today, and we'll spend the next 10 minutes talking about this and then open it up to questions, is recovery, the many paths to wellness. I can't tell you how excited I was when we got approval to include a chapter on recovery in the report. I know a lot of you probably think that would have been a given, right? That there needs to be a chapter about recovery. How can you do a report about addiction without talking about recovery? But there's not widespread support, and there's not great, well-supported scientific evidence for recovery support, and for all types of recovery support. There is for certain segments of recovery support. And so some people did not want to include this in the report. Some people thought that this would be somehow compromising the scientific rigor of the report. And we were able to argue, and successfully argue, that a report about addiction without recovery is not a full report. And so this chapter got added. The senior scientific editor on the report was Keith Humphreys, who is out of Stanford University, and he's done a lot of his work around mutual aid groups. Keith had lots of people help him on the report, like Dr. John Kelly from the Recovery Research Institute at Harvard, Alexander Laudet, all the names of recovery researchers that you have ever heard in your life were involved in writing or reviewing this chapter, and really helped us make sure that it met the scientific rigor that the CDC required to get it over the finish line, and for us to get this through a government clearance process and through a White House that in the final year of their administration, we're not looking for any controversy. This describes the construct of recovery as well as the number of people in recovery, describes the growing array of effective services and systems that provide recovery support, and the many pathways that make recovery possible, including treatment, recovery support services, and/or mutual aid. It's by far the happiest part of the report. It's what we call the hope chapter of the report. Because it affects such a huge number of people, but it really gets discussed. David mentioned I make a cameo appearance in Anonymous People, and Anonymous People was what really opened my eyes to the fact that we don't talk about recovery enough, that so many of us who find recovery, we end up getting our lives back, and then we fade back into the woodwork. Well, this is a really important chapter because it helps us come out of the woodwork. And this is an issue that everyone in our diverse country can get a hold of. It's about identity, culture, values, and politics as much as it is about health. This is really an important part of this report. It talks about what recovery is for individuals, objective remission, plus subjective understanding, plus change that happens in someone's life beyond their substance use. And that's really important. For other health issues, the change requirement isn't as important as getting over the health issue. For us, we know change is a critical part of it. Recovery is important for movements and communities too. That's where we get into this set of values and actions. And it can be different for everyone, right? Those of you who are involved in recovery community organizations know that. You know that we invite a diverse group of people to the table, and we have to meet people where they are in terms of their own values and their own actions. The difference between remission and recovery, it was really important to talk about in the report. Remission, of course, is a medical term, meaning that major disease symptoms are eliminated or diminished below a predetermined harmful level. Whereas recovery, and this is the SAMHSA definition of recovery, is a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. Even individuals with severe and chronic substance use disorders can, with help, overcome their substance use disorder and regain health and social function. When those positive changes and values become part of a voluntary adopted lifestyle, that's called being in recovery. Although abstinence from all substance misuse is clearly an important feature of a recovery lifestyle, it's not the only healthy pro-social feature. About 1 in 10 American adults is in recovery, in remission, I should say, and that's reason for hope. There's subjective definitions of recovery because they're somewhat diverse, right? In some people define recovery as once having a problem with alcohol and other drugs and resolving it. And that's what this survey that's quoted millions of Americans that were reported being in stable recovery, that was their definition. But we know there's many pathways to recovery. And so everybody has a different definition. And it's really hard to talk about recovery as being a monolithic event, right? It's something different for everybody. As part of the many pathways to recovery discussion, we need to recognize that many people, or most people in remission, did not seek specialized help. For those that have, all treatments have been involved, including medication. And that's, I know, can be controversial in the recovery community. If for some people who have an abstinence pathway, they don't accept that people using medication are in recovery. And we need to change that. That needs to be part of what we change. And when we become more accepting around the many pathways to recovery, that starts to happen. The most common source of support sought in the United States is mutual help. And we'll just talk a little bit about mutual help groups. They're peer-led and created. They're free of charge. They're informal, and therefore highly tailorable to the individual's needs. Alcoholics Anonymous is the largest, most widely accessed and studied. There are many 12-step variants, but also a lot of different options for mutual help groups outside of 12-step. Mutual help has an evidence base. There's strong evidence that supports the effectiveness of Alcoholics Anonymous. And the great thing about the Surgeon General report, it doesn't just say that there's strong evidence, then it goes to the report itself, which is over 400 pages long, by the way. But you can go to the recovery chapter and you can look up the strong evidence that it cites. And you can see the different studies that have been conducted on Alcoholics Anonymous. There's moderate evidence that supports other 12-step fellowships like Al-Anon, Narcotics Anonymous, and Cocaine Anonymous. But there's much less known about other mutual help options. They just haven't been studied as much. Recovery support services are also covered in this chapter. And we know there's a mix of funded and voluntary services. They're based heavily in recovering people's knowledge. They're usually staffed and created by people in recovery. And there's many different types. Keith Humphreys liked to refer to this as a fertile period with many flowers blooming. The strongest current evidence for recovery for these programs are recovery housing and recovery case management. So Oxford House in particular has been studied through randomized controlled trials and has super strong evidence. Recovery as a higher level organizing principle. We all know the age-old, at this point in time, age-old terms, recovery-oriented systems of care. This is something that SAMHSA piloted and spent a lot of time and resources helping to implement throughout the United States, trying to think of recovery as being the end game for any activity that happened along the continuum, and really help people get into that mindset that what we're really trying to prepare somebody for is long-term recovery. And we also know that the recovery movement, this burgeoning recovery movement that has been around for a long time, probably since Bill Wilson tapped Marty Mann to lead the National Council on Alcoholism back in the 1950s, and has continued to this day with organizations like Facing Addiction or Faces and Voices of Recovery, or many of the other organizations that exist and that have really brought the community together to speak on its own behalf and to advocate for the kinds of changes that are necessary. So the recommendations out of the recovery report, and by the way, each of the chapters has recommendations at the end of it. I didn't cover the ones from the other chapters because we don't have enough time today, but we really need to celebrate and support recovery, but not take it over. It doesn't need to be taken over. It's working just fine as it is. We need to make healthcare systems permeable to recovery concepts, people, and organizations. You've seen a lot of that starting to happen through things like recovery coaches in emergency departments. That never used to happen before. That's a rather new concept. Invest in evidence-based recovery supports. It's funny that we throw a lot of good money after bad in this system. We spend a lot of money on detoxification and treatment services. And like I said, once we cut those off for somebody, they don't do very well. So we need to invest in longer term bundles of care that stick with somebody for a long period of time. And we need to expand research on this novel, exciting recovery support concept that's emerging in diverse communities. So I'm going to end just by talking about the very last chapter of the report, which is called A Vision for the Future. It really calls on us to take a public health approach to addiction. I'm not going to read through these slides, but just to say that this exists in the report. The report identifies a vision for the future and then gives you very concrete things that we could do to help put forward that vision for the future. And then there's recommendations in that chapter for stakeholders, and that's what I wanted to call your attention to today. So you guys can help change the culture, attitudes, and practices around substance abuse if you're in one of these categories. If you're in this is obviously everybody, but individuals and family members, educators and academic institutions, healthcare professionals and systems, communities, private sector, industry and commerce, governments and researchers. Stakeholders really can work together to address substance misuse. We got to mobilize community leaders and systems to address substance misuse and associated harms. There's a role to play for everybody, religious institutions, law enforcement, local businesses. You've seen this happen a little bit in the opioid crisis, where people have come together and really worked closely together. from various sectors of our community to address the issue of people dying from opioids. And stakeholders can help change the culture, moving toward a public health-based approach, which involves addressing individual, environmental, and societal factors that influence substance misuse and its consequences, and create a society where communities are willing to invest in prevention services, people feel comfortable seeking treatment, healthcare professionals treat substance use disorder with the same level of compassion as other chronic diseases, and people are celebrated for efforts to get well and for their steps in recovery. There's a website, addiction.surgeongeneral.gov, which has the full report on it. You can download a PDF copy of the report on that website. I briefly mentioned the opioid report. There's also, that is up on that website, and you can download that. There's an executive summary. If you're not super comfortable reading the full report, all 400 pages, it's as thick as a phone book. You can read the executive summary, which is much more digestible, or you can just pick up one of the individual chapters and check those out. The website is really great. It's a responsive design website. We spent extra money to make sure that this website was accessible on all platforms. So you can access it from your computer, you can access it from your phone, you can access it from your tablet. Doesn't matter if you have an iPhone or an Android or something else. It's really accessible. And then we also took the time to create supplementary materials that you can download. There's posters, there's checklists, there's all sorts of materials that can help you go out and do community forums, town hall meetings, have discussions about the information that's in the report, and let people know that the report exists. Because with a Surgeon General's report, that's one of the most important things, is that people know that the Surgeon General of the United States, the most credible government employee, has taken a stand and has said that this, how we deal with addiction in America, and he says this in his letter in the very opening part of the report, how we deal with addiction in America is a moral test for our country. And with that, I'm going to turn it back over to David, and I have time to stick around and answer any questions folks may have.
Thank you, Tom. I really appreciate that, and want to open it up to questions. I think maybe just to start off, Tom, one thing that we were talking about yesterday for the King County Recovery Coalition Advisory Board is how communities of color have been disproportionately impacted and under-resourced, particularly in the area of recovery support, and what thoughts and advice, suggestions do you have for organizations at all levels to address this issue?
That's a great question. The report really doesn't get into that in significant detail, but we obviously do talk about behavioral health equity in the report and the importance of it. And many of you guys know that I'm currently a regional administrator. I'm back at SAMHSA in this new role, and I just got off a call before I joined this one about this very topic. And clearly, the civil unrest that's percolating in our country, or some might say has exploded in our country, is long overdue, right? We really need to focus more clearly on issues of equity within behavioral health. I don't have a lot to offer in that, but we do have an entire Office of Behavioral Health Equity. We have lots of resources at SAMHSA that I'm happy to make available to you, David, for the coalition. We're really trying to take this very, very seriously. SAMHSA has for many years. This isn't kind of a new concept just because of the current civil unrest. SAMHSA is known for a long time that we need to be a leader, and if we're going to make a difference here, and we're going to make sure that everybody who needs help is able to get the help that they need, we need to provide the resources to make sure that that happens.
Yeah. Thanks, Tom. I have other questions, but I want to open it up to the larger group if people want to put their questions in the chat. Okay.
Why don't you add, here they start to come. why are there few randomized controlled trials? That's a great question. Mostly it's because of the cost of doing a randomized controlled trial. So they traditionally have not been funded, and the reasons can be, we can speculate, but clearly I think stigma becomes a major issue. We know that there's negative public attitudes when it comes to the treatment, the identification and treatment of these illnesses. And I think what is happening is you've seen over the years where other diseases that may not have as many negative public attitudes associated with it, like cancer or heart disease or any other disease that we can talk about, there's been a movement afoot to really make sure that the NIH or other government agencies fund clinical trials in this area. And so we need to make sure that for addiction the same thing occurs. And so there needs to be an advocacy push to do that. I'm happy to say that Congress in the last budget cycle funded a big initiative at NIH, mostly associated with the opioid crisis. There's two parts to it. One is the first part of it is to find new medications for addiction that are effective. Right now, we have only a handful of tools in our toolbox, right? We have 3 medications we know for opioid use disorder. We have a couple of medications for people with alcohol use disorder. And beyond that, we come up empty. So we need to find those medications and the research that will help develop them. So I think the reason is that they're costly, they take a long time to do, and there's negative public attitudes preventing the money to flow into NIH to do those projects. Let's see. Are you reading the questions, David, or am I?
I think if you can see them, let's have you go. We'll be more efficient. Thanks, Tom.
Tom or David? This is for either of us, David.
Why don't you take it, Tom?
You're not going to give me a little break? Question for Tom or David. It's been shown that there's a strong correlation between sobriety and employment, yet I don't hear many people talking about this. Are you aware of any community or government initiatives to let prospective employers know that hiring people in recovery can be good for business and their community? Yes, I do. First of all, that is true. And we know, Samson knows through the 4 dimensions of recovery, right? We know it's home, health, purpose, and community. And part of purpose is employment. Part of community is employment. I mean, and Samson developed and ran the ATR program for many, many years, which had a focus on making sure people in recovery got jobs. We know that that's critically important. When I introduced myself, I talked about what was the first thing I talked about. I talked about the ability to have these jobs in government to be able to make a difference. It's no secret that I stayed in recovery because I had a job and I had a purpose in my life, something that was really important. So the U.S. Department of Labor, as part of their opioid crisis response, used their dislocated workers program and gave grants to states around the country to set up recovery-friendly workplace campaigns. There's 2 I know in my region. One is in New Hampshire. They're the very first, and the governor of New Hampshire actually got behind this initiative. And there's a guy that is involved in the recovery community, Marty Bolden, who was the brainchild behind the recovery-friendly workplace initiative in New Hampshire. You can look it up. Recovery-friendly, I think it's recoveryfriendlynewhampshire.com or something, but you could look that one up. And Rhode Island followed suit shortly thereafter and set up their own recovery-friendly workplace program as well. There's a couple of good things that have come out of those programs. Number one, they have been able to share with workplaces the importance of hiring people in recovery and how people in recovery make great employees, and that you have to reduce the barriers that people have to employment to get them in And once you do, you have a great employee. But also, there's already people in the workplace. You know, I mentioned to you that most people who have a substance use disorder, they didn't go to formal treatment or get in, you know, go to as they got into recovery pretty much as a self-corrector. They went, you know, they got to the other side of their addiction. So most of the people who are in workplaces that have a problem with substance use, they need support, they need help, they need to know that it's okay not to be okay, right? And that they can reach out to their EAP or any their health insurer, whatever resources they have available in that company. We're also seeing a great number of employees who have workplace stress related to a family member's substance use. So these programs have not only helped people get into the workforce and get these jobs in workplaces that are recovery friendly, but it also has helped employees that are there right now and family members who are there right now to get the resources that they need. So yeah, super important. Thanks for bringing it up. And those are two great examples. I think Sioux Falls and the folks out in South Dakota also have a program that they've worked with Chambers of Commerce on, which is a little different than Recovery Friendly Workplace, but similar, same church, maybe a different pew, but a lot of the same information. So any significant work being done on stimulant addiction, treatment, and medical intervention. So stimulants are incredibly complex, right? Because we know we don't have an opioid crisis in this country. We have an addiction crisis. I think everyone on this call can agree that that's the case. Yet the shiny object for several years has been opioids. And it's gotten the media to stand up and pay attention to something that they never did before. It's gotten Congress to stand up and pay attention. It's gotten other folks in government, state and federal, local governments to pay attention to things they never paid to before. So I'm all for that, but as long as we understand and use those resources, as I like to say, to lift all boats, right? We need to make sure that whatever type of programs we're putting together, that it's not just good for somebody with an opioid use disorder, but just as many people die every year of alcohol use disorder as do of opioid. It takes longer to die of alcohol use disorder. Most people don't die of acute alcohol poisoning. Most people die of, cirrhosis of the liver or another associated health condition, but the same amount of people die. So we need to be doing something. And the same things with stimulants. Now we're seeing, there's a lot of states that don't have opioid crises. They have meth crisis. They have a cocaine crisis. So we need to definitely pay attention to that. Congress this year finally allowed state opioid response grants to be used for stimulant use disorder. The problem is we don't have medical interventions for stimulant use disorder yet. That's something that still needs to be studied and developed. So what we're relying on is residential treatment typically. We're relying on other evidence-based practices like CBT or other evidence-based practices that are used in treatment settings, which typically involve somebody either being in an intensive outpatient program, but preferably in a residential treatment setting, depending on the severity of their condition. But that's the problem. We don't have enough of those resources available to make sure that everyone who has that disorder gets the help that they need. So hopefully with the loosening of the regulations around using opioid funds for stimulants, some of that will start to take place. Looks like there's a question here about fentanyl, demand reduction, supply reduction. Yeah, so I'm not sure exactly what you're asking there, but
well, Tom, that'd be good can we unmute Brad? Brad, could you clarify your question?
I mean, I don't know if it's ever good to unmute Brad, just for the record.
Well, I agree with that, but maybe this one time we'll give it a shot.
I mean, I guess, Tom, thanks for taking the question too,
Sure.
Being here with us today. My question is from a federal level, like, the fentanyl overdose issue is threatening. I mean, it's very different on the East Coast than it is the West Coast, but it is very much an issue of, no matter how you look at it, it's probably fentanyl coming in from China into, Mexico and making its way north with different routes with, sometimes in substances that like heroin and methamphetamine, sometimes in counterfeit pills. And
right.
I mean, I think everyone's just having a hard time getting, in front of it. And so, I think we're looking for wisdom, and what, like the approach of, is it a demand reduction or is it reduction?
Okay. Well, yeah, thanks for clarifying that, Brad. I think it's both. It's a both and, right? It's you can't have one without the other. And I think we spent years and years as a nation trying to do one over the other, and in doing one so much, we've resourced one so much more than we've resourced the other. So you have to do both. So you have to be, and I think we've done a good job of trying to balance it up, but it's still lopsided in terms of the amount of money we spend on interdiction versus the amount of money we spend on treatment and recovery support services. So we need to balance off that a lot further. But it's really a complex problem, right? Especially when it's coming in, it's being sold over the dark web, and it's being transported in the mail, and they can only scan so many packages and find these substances in so many cases, right? So that becomes very, very challenging. Most of it is that's what I'm hearing from our local HIDA, is that most of it's coming in the mail, and it only requires a very small amount of fentanyl, right, to be added to a drug supply in order to kill thousands of people, and it's such a complex thing. And in New England, most of the New England states, we're seeing, we very rarely see straight opioid overdoses anymore. It's all fentanyl now, or it's fentanyl mixed with a stimulant. So I wish I had better. I wish I had, the panacea for that, but I don't. But we need to stay on top of the federal government to make sure that they're balancing out supply and demand reduction, and we need to make sure that harm reduction is part of this. Is part of the equation too, right? I'm using the term harm reduction because that's the common nomenclature, but I like to call it health promotion, where we're actually working with people to get them to make healthier decisions, right, every single day. And we need to make sure that we have flexibilities in order to do that. And oftentimes we don't have the legal flexibilities or the community support. Because again, we get back to a moralizing of the addiction crisis as opposed to a treatment of the addiction crisis. So I hope those are helpful thoughts. Anyways, we could have an entire meeting about just that. The next question is from Jamie. I'm struggling with effectively supporting individuals exiting homelessness with the use of Housing First model. I do believe in the Housing First model in theory, but I'm watching some people get worse moving into housing, not better. Yeah, this is, any thoughts, ideas, insight around this? Well, this has always been one of my pet peeves, and I have been really, really vocal about this. I support the Housing First model too, for people that it makes sense for. Oftentimes people who are struggling from addiction, by the way, Heather, I think we're still spotlighting Brad, and that might make him feel uncomfortable. He might love it. I don't know, but we're spotlighting. Don't worry about it, Brad. You're doing great. The Housing First model really does a disservice to people sometimes who are trying to find recovery, right? Because it's wrapping around an entire set of services around somebody. Well, first it's giving them housing, which is important, and we know they need it. But once they get the housing, their motivation to do other things in recovery, other recovery tasks that need to be done, are diminished. And we all know, people who work in the field know, that sometimes you need those motivational points, right, to help somebody on their path, right? Who's gonna go through Prochaska and De Clemente stages of change when they've already been given the one thing that they seek, which is that roof over their head? And I know that's a complicated conversation, because do we say we leave people outside and we don't house them if they don't want to get the help? That's the problematic piece of this, right? So housing first, really, for me, I just try to separate it. Housing first are not necessarily the model for people looking to get help. Housing first is the model for people looking to get housing. Addiction treatment, recovery support services, recovery housing is the place where people go if they're looking for recovery. And I hope I didn't open up an entire can of worms with that, but that's long been my issue, that housing first is not recovery oriented. Housing first could become recovery oriented. You can look at models like Central City Concern, which is just a neighbor to your south in Portland, who does an amazing job of both, right? They do housing first, they do recovery oriented housing first. That's an entirely different situation. And I think that's something I can get behind and I can support. But other models I've seen cause more damage to folks, as you indicate. So yeah, I'd send people more on the treatment route and the recovery housing route, as opposed to the housing first route. That would be my thought. Brad's also interested in SAMHSA's role in funding permanent supported housing. So SAMHSA doesn't typically support permanent supportive housing. We do have a CABI grant. We do have a few different grant programs that support housing, and we do allow our funds to be used to support housing, like recovery housing. I know several states are using SOAR funds to create vouchers, just like in the old ATR model, to give people recovery housing. I know in Rhode Island, in my home state, they have a great grant program for recovery housing right now, where you get 1 year of recovery housing under the SOAR grant. I think the first 6 months is at 100%. The next 3 months is at 75%. I'm sorry, first 3 months is at 50%. The next, first 6 months is at 100%. Then it goes down to 75, 50, 25%. So just to kind of get somebody, the help that they need so they can get on their feet, get a job, start working, and then pay their own rent. So we don't really have a role in permanent supportive housing, but we do support recovery housing and other types of housing with our grant programs. There still has to be more clean housing options and options for sex offenders. Yeah, I couldn't agree more. I think I covered the clean housing part. It's not my area of expertise, the sex offender housing that you mentioned, though. Sorry for all the questions, but Brad has another one. But how can we advocate for naloxone to be allowable in SAMHSA grants? They are forbidden in most. Is that true, Brad? I don't know that to be true. I think naloxone can be purchased with.
It is, in many of the SAMHSA grants, and most of the ones that I've had apply for, and many actually that I've been a reviewer for, naloxone is a non-allowable expense in almost all of them.
Are they mental health grants? Is that why?
No, they're SUD grants. They're SAMHSA SUD grants.
Really?
Yeah.
I'll have to get back to you on that, because I'm not aware of that. So I'm happy to get. I'm taking a little. I'm taking some notes here, and we'll follow up with some of the things that either you've asked for, or I don't have the answers for.
Thanks. I'm conscious that we're running out of time. I think there's Jamie has a question, and I know one thing we wanted to ask you was just your thoughts for going forward for the whole system in a light of COVID. But very conscious of how valuable your time is, and appreciate you coming with us today. And then I know Heather's going to bring us home maybe after those two questions.
Sure. So any advice on effectively advocating for models like CCC and the largely HUD funded system? Is there another entity I should be appealing to besides homeless crisis response system? Yeah, we can talk offline about this because this starts to get a little complicated. And I can also try to hook you up with somebody who has a little bit more experience in the housing realm, Jamie. So feel free to grab my information from David or Heather and reach out. By the way, SAMHSA has a page at samhsa.gov. There's a page for regional administrators. All of our contact information is up there, and you can just click on it and pop us an email. And last but not least is Cheryl naloxone can be purchased with SABG and SOR. Okay, so that takes care.
Tom, maybe as a final question, could you just talk about your perspective with our whole system now and how COVID has changed everything from in-person 12-step meetings to, there's some articles here about treatment centers that aren't going to make it.
Yeah, we're starting to hear that, and that's unfortunate. We know a lot who have applied for aid, and people who are Medicare and Medicaid providers are eligible for relief funds now. There's a provider relief fund, and we're hoping that will help people. But COVID certainly has changed the nature of our business. Obviously, it's put a lot of pressure on providers in a very short time to have to pivot. It's put it's also put that same pressure on recovery support systems who have all had to go virtually overnight. I've been very impressed with the recovery community and how they have come together and supported each other virtually. And one of the things that we like to say at SAMHSA now is that we hate this term social distancing because we don't believe anybody should be socially distanced. We think they should be physically distancing according to CDC guidelines, but please don't social distance. Please don't isolate. Get on a Zoom meeting, call a friend, text somebody. We are resilient. People in recovery are resilient. We kind of have had the most training in resilience of anybody in our communities. And so we need to stick together and be able to help each other through that. SAMHSA is advocating to the administration to make more resources available to providers so that they can stay afloat. We already know that there's a shortage of providers, and losing one provider in a community would be too many. It would take outpatient slots offline and residential treatment slots and medication slots and other type of services that people rely on to stay alive, and it's totally unacceptable. But again, while COVID has been a bad thing for the entire world, we have seen little glimmers of hope from COVID, like the virtual presence that people have been able to maintain. We've also seen flexibilities in telehealth that never would have happened without a global pandemic, and medication-assisted treatment as well. Many of you know that SAMHSA and DEA have relaxed regulations around first-person visit for both buprenorphine and methadone, and have allowed up to 28 days of take-homes for certain patients who are in clinics and OTPs. So it's been, while it's been obviously a very bad thing, COVID-19 has also helped us, I think, in a lot of ways recognize that we could offer different flexibilities and the sky has not fallen, and that maybe we should be treating these illnesses like we're treating other illnesses and not stigmatizing them as much through onerous regulations and making patients and providers jump through as many hoops as they've had to jump through in the past.
And Tom, thank you for all the work that you've done in that regard. I just want to again say how much we appreciate you being here. And I know that I mentioned that maybe we might hit you up to come back again in the future.
Yeah, absolutely.
I appreciate that. And I think, Heather, do you want to bring us home then? Unless you have a last thought for us, Tom.
Just thank you for this opportunity. Now more than ever, I think this is an opportunity moment for recovery community organizations like the Washington Recovery Coalition or the Seattle Recovery Coalition. I think it's you know, this is an opportunity that we really can use to help advance a lot of the things that we've been fighting for many years. So let's not lose this opportunity. People are depending on us. They need us now more than ever.
Thank you so much, Tom and David, for a wonderful afternoon and conversation around recovery support services. We're so grateful to have you join us today. It's such an important topic. For everyone, thank you for spending your afternoon with us. And if you would like to get more involved, like Tom talked about, and learn how to use your voice and your story to advocate for change in policy affecting behavioral health, please join us at the King County Recovery Coalition, and also there's 9 coalitions around the state that are part of the Washington Recovery Alliance. So whatever area you're in, you can find your local chapter of our recovery coalitions and get involved. And you can go to our websites, WashingtonRecoveryAlliance.org and KCRecovery.org if you'd like to get involved. Our next presentation of KCRC Presents will be a community conversation in July, on July 30th. About the role of state, county, and city governments in behavioral health systems. And we will be having a panel of our elected officials speaking with us that day. So we hope you'll join us. And the link is here to register. And I am betting Teresa will be putting it in the chat for us momentarily. Thank you so much. We're so grateful to have you here with us. Have a wonderful rest of your day.
Thank you, everybody. Have a great day.
Thank you. Thanks so much, Tom.
Thank you, Tom.
Thank you.
Thank you, David.
Thank you, David.
Teresa.
Thanks, Heather and Teresa. Yep. Appreciate it, guys.